So, good afternoon to all joined for this course on palliative nursing. I'm audible, no? All can hear me?
Yes, Namaste.
Okay, fine. So, we are going to present the scenario which is given to us. Just before starting, to introduce the scenario, we would like to show a video. You just can go through on it. This video is made by Dr. Bhaskar and Akila. We are just sharing the video first.
Sorry, ma'am. Did you ask something? Sorry, I missed.
Mrs. AJ is a 38-year-old woman living in a small rural village. She supports her husband and 3 children by tending a small kitchen garden, providing a critical source of food and stability for the household. The family's survival is balanced on a razor's edge, relying entirely on the modest income her husband brings home as a daily wage laborer. About a year ago, Mrs. AJ noticed the first sign that something was wrong: a foul-smelling vaginal discharge that she couldn't explain. Because she feared being judged by her neighbors, she kept the symptom entirely to herself. She did not tell her friends, she kept it from her family, and even her husband. This diagram tracks 2 downward paths from the first symptom. As biological disease progresses, a second trajectory, social isolation, descends alongside it. The isolation path drops first. When reproductive health is taboo, silence isolates the patient before physical illness takes hold. Without an open conversation, a condition that could have been treated in its early stages is left to advance toward a far more dangerous phase. As months passed and the cancer went untreated, the physical odor became impossible to ignore. Neighbors and family members began to notice. Instead of offering support, they began to whisper, keeping a visible distance from her in the village. Mrs. AJ felt the weight of these whispers. She was consumed by a sense of shame that kept her trapped in her home. Her fear of being branded an outcast was more immediate than her fear of the illness, so she continued to delay seeing a doctor. It was only when the symptoms became physically overwhelming that she finally visited a local clinic. In this environment, social judgment acts like a secondary infection. It paralyzes the patient, preventing them from seeking the care that could save their life. After being referred to a government hospital, Miss AJ received the diagnosis: advanced cervical cancer. This chart compares medical costs. While early screening is inexpensive, treating advanced cancer is massive, far exceeding a daily wage laborer's earnings. Faced with these costs, Mrs. AJ refused further treatment to protect what little money her family had left. She returned to her village, trying to manage her symptoms using old rags and newspapers. For a family on the edge, poverty limits healthcare options. It ends the possibility of survival once the early intervention window closes. The cancer continued its unchecked, aggressive progression. Mrs. AJ suffered through constant pelvic pain, increasing physical weakness, and severe weight loss. The lack of proper medical supplies led to further complications. Urine leakage caused painful, severe skin ulcers, making every physical movement an absolute agony. She eventually became too weak to tend her garden or manage the house, losing the very activities that gave her a sense of purpose. Fearing her condition was contagious, her family and neighbors stopped visiting her entirely. Untreated illness and social stigma work together to strip a person of their dignity. By the time the cancer reached its final stages, Mrs. AJ had already been treated as if she were no longer a part of her community. A hospital-based palliative care team eventually found Mrs. AJ during a local community awareness program in her village. The team provided specialized care to manage her pain, but their work also focused on restoring her sense of worth. When the medical team physically touched and comforted her, they sent a message to the village. Her condition was not something to be feared or avoided. Cervical cancer is a disease that can be prevented and treated, provided it is caught in its earliest stages. To stop this cycle, communities must find ways to talk about reproductive health openly, so women feel safe seeking help the moment they notice a problem. Saving lives like Mrs. AJ's requires two things: medical intervention to treat the body.
Yes, I hope you must have seen this video. If anyone just present, put some message in the chat box. What did you get from this? Okay, so we are here to present the case, the scenario which is given on Mrs. AJ, dimensions of palliative care, models of care, and role of nurse in this case. So this is a case scenario which is given to us. Mrs. AJ, 38-year-old woman living in a small rural village with her husband and three children. Her husband works as a daily wage laborer and the family survives on a very modest income what he brings. To support the family, Mrs. AJ tends to do a small kitchen garden. About a year ago, she experienced foul smelling vaginal discharge. Out of embarrassment and fear of being judged, she did not tell anyone, not even to her husband. Over time, the smell became more pronounced, drawing comments from family members and neighbors. Only then did she visit the local unit, then where she was referred to a government hospital and diagnosed with advanced cervical cancer. So, due to financial constraint, she refused further treatment. She managed the constant vaginal discharge by using old rags and newspapers. As the disease progressed, she developed pelvic pain, increasing weakness, anorexia, and significant weight loss. Eventually, she experienced urine leakage, leading to painful ulcers in her inner thighs and buttocks from constant wetness and poor hygiene. She could no longer tend her garden or manage basic household chores. This led to a deep sense of worthlessness and depression. The persistent smell caused her family and neighbors to distance themselves from her. So, fearing her condition was contagious, isolated, and feeling like a burden. So, she began to see herself as an outcast. So, she was identified by a hospital-based palliative care team during a community awareness program in her village. So, this is a scenario which is given to us. So, from this, just a points to note, important points to note from this scenario: the demographic characteristics of the patient: a 38-year-old female living in a rural area, married and having three children. Her husband is a daily wager. Her occupation is doing a kitchen garden. Their income is very poor and very they are in a poverty level. Regarding the clinical summary, what we could get from this scenario, she was diagnosed with advanced cervical cancer. Symptom onset is about 1 year ago, and there is delayed health seeking. Initial treatment was not done, and there is a financial barrier also to seek treatment. And she was diagnosed in a government hospital. And at this stage, she was identified by a palliative team. So, this is a summary of the scenario what is given to us. So, disease progression and barriers to care, if we look at here, the first symptom which was noticed is foul smelling vaginal discharge. So, this is how the symptom identification started, and it led to a social stigma That is why there was a delay in care seeking. So she felt that this is a stigmatized, people will have justification behavior on us. So she did not reveal her symptoms to anybody, kept it with her. As the disease progressed, she was diagnosed with advanced cervical cancer. Once the symptoms worsens only, she went to a hospital. Because of the financial barrier, she was not in a position to continue the treatment, and last identified by a palliative care team. So these are all the stages by which the patient had come across in this disease. So key symptoms at the time of palliative care identification is persistent foul smelling vaginal discharge, pelvic pain and significant weight loss, urinary incontinence and painful skin ulcers, and severe weakness and anorexia, social isolation and depression, poor hygiene due to lack of resources. So these are all the palliative care needs which the team identified. So in this case presentation, our objectives are to identify the multidimensional aspects of palliative care in a real-world oncology case, evaluate and select an appropriate model of palliative care for a patient with advanced cancer, describe the comprehensive nursing role in delivering best supportive care. So to introduce this, 61 million adults experienced serious health-related suffering globally. 80% of them are from middle and low-income countries. 7.2 million of them are Indians. 2.5 million children die due to severe health-related suffering every year. So this is a reference which is taken from Lancet Commission report, Indian Journal of Palliative Care. So this significantly shows how serious the problem is and how much people are in need of palliative care. So palliative care is an approach that improves the quality of life of patients even at the last stages of life. To some extent, it improves the quality of life when their families facing life-threatening illness through prevention and relief of suffering by early identification, assessment, and treatment of pain and other physical, psychosocial, and spiritual problems. So this is by WHO. So here the components are improving comfort, dignity, providing support, and family support is essential. So relief from pain, breathlessness, and other severe worsening symptoms to promote or enhance comfort of a patient is important. And maintaining or respecting individual dignity and values and patient's autonomy is another component. And they require lots of support, especially emotional, psychological, and social spiritual support. And family support for the patient's family and caregivers are highly essential. So caregiver support and caregiver strengthening empowerment is highly needed in palliative care. So with this words of introduction, I hand over the presentation to Professor Sophia. She will continue the rest of this case presentation. Thank you.
Good afternoon, all. Um, Through the video as well as from the introduction, you might have listened to the scenario of our patient, Mrs. AJ. So, what do you think? She had vaginal discharge, she was isolating herself from others, she has financial constraints, so many problems are there. So, we will be looking on to the various dimensions of palliative care. Before we could move on to the various dimensions of palliative care, I would like to highlight the uh, dimensions of health or the definition of health as such. I hope you all might know like the World Health Organization's definition of health. As we all know, health is a state of complete physical, mental, social, emotional, spiritual well-being, and not merely the absence of disease or infirmity. So, from the definition, we come to know that it is not only the physical dimension, or it is not only the emotional dimension, or it is not the social or the spiritual dimension, where a person must have a balance or equity with all the dimensions to say him as a healthy individual. So same applies to palliative care also. So in palliative care also we have physical, psychological, social, as well as spiritual dimensions. So here, uh, From the scenario, you might have heard about various symptoms. Can any one of you tell me what all can be categorized under physical dimensions or physical symptoms that the person was having? And as a nurse, what are all the aspects that we have to focus on to manage the patient physically? Can anybody unmute and answer what can be categorized as physical? Participants, are you all there?
Dear participants, kindly reply.
Dear participants, those who could unmute yourself and speak up, and those who can put your cameras on, it's like we welcome you all.
Yeah, pain,
Ma'am, they are saying pain, physical pain, pain.
physical pain, good. Any other physical symptoms that you can say or you can categorize under physical? Anybody else? Abhisha? Yeah, foul smelling discharge. That is also categorized under physical symptoms. Yeah, patient was irritable. Partly it can be physical, partly it can be psychological. Yes, thank you for your answers. Let us see like what all we have categorized under physical. So focus only on the first category as physical. It is foul smelling vaginal discharge, pelvic pain. A patient was having pelvic pain and weakness, and also she had anorexia, that is loss of appetite, and weight loss. As the day goes, like she was having reduction or there was weight loss, and urinary incontinence was present, and also she had skin ulcers because of the wetness that she had in the thighs and the buttocks. She had all these symptoms. So these we have categorized as physical symptoms. And moving on to the psychological, in the scenario itself, you might have noticed she was under extreme depression, hopelessness, because due to the financial constraints one side, and also she had fear. Okay, she don't know like what is her future, what like she mentally had certain what to say perceptions like how will be my life going on, because three children were there, who will take care of those children. And also she had shame because she perceived or she had intention that this particular disease can be like somebody will judge us, as in the introduction also we said. And also the stigma that was existing because it was a foul smelling discharge, nobody was coming near to her. Mentally she was disturbed, and fear of judgment as well as worthlessness. Yeah, we can also look for potential issues. Okay, so worthlessness and anticipatory grief. Anticipatory grief, where like a person will think profound depression will be there. What will happen next, or what will occur to me in the future? All these manifestations can be categorized under psychological manifestations. And moving on to the social dimensions, like social isolation, she was not talking or she was isolating, and even others behaved in such a way that they were maintaining some distance with her. Family as well as neighbor withdrawal was there. And in the video also we seen under the scenario also, previously she was maintaining a kitchen garden, and later she was not able to perform that role, and all her garden was not flourishing well. And the role of gardener as well as the mother, okay, she had a loss of role. And financial hardships, like the husband was a daily wager, and because of the treatment, what money is needed for her treatment, that is a big question mark for her. And even if she had to go to the hospital, even if she has to go for a treatment, the money and the transportation, everything matters for her. And also she perceived it as contagious, it is communicable, that was the thought she had. And all these we categorized as the social, which comes under the social dimensions. And the last component is the spiritual dimension, where many of the people especially when they hear the word cancer or when they hear the word terminal illness, everybody will undergo the stage of TAPDA, where depression, anger, bargaining, denial, depression, and at last the person goes for a stage of acceptance. Okay, so here people think, or our patient also was thinking, what is the meaning of my life? Why at all I have to be born? Uh, why this particular disease condition was affecting me? Why God has punished me a lot? Okay, so many things was happening into her mind, and existential distress was there. That means profound depression. The person was in profound depression and outcast self perception. Like, just because many people was not talking to her and they were not mingling with her properly, and she was undergoing abuse, or she was undergoing, what to say, some kind of bullying, like people were not open to her, and that was her perception. Outcast self perception was there. So many questions was there on her mind. What should I have to do? How the remaining part of life will go for me? Okay, why at all is, whether God is there or not? Okay, maybe so many questions may be in her mind, and spiritual abandonment can also take place. So these are all the various dimensions. So as a nurse, we need not only focus on to the physical aspect of care, but also on to the psychological, social, as well as the spiritual dimensions also we need to look into. And in palliative care, as Dame Cicely Saunders, he rightly coined a word called as total pain. Okay, what he wanted to stress on this terminology, total pain, is if a person has the pain is a collective pain where all these dimensions put together, and that is what is called as the total pain, where physical, psychological, social, and spiritual together, it may cause intense pain to the patient. It is not only the physical pain that the person perceives, but also all these components are also intertwined, and together the person has pain, and that is termed as total pain. And that was the term coined by Dame Cicely Saunders. And as nurses, if there are measures taken to reduce the total pain, then only the person's quality of life improves. That is what is the ultimate modality of care that we have to give, where we should not only focus only on to the physical aspect of care, but also the psychological, social, and the spiritual dimensions also need to be taken care, where the patient is relieved from the total pain, or there is reduction in total pain, which in turn helps the person to improve the quality of life. And that is what we would like to stress on the various dimensions of palliative care. And we will move on to the next topic, where it is models of palliative care. So, moving on to the key models applicable in palliative care practice, just I would like to highlight what are all the various models that has been stated in palliative care. The first one is home-based model, where the name itself you can identify, home-based. That means the care is delivered to the patients at the home by a trained people or trained team, best for rural patients with limited mobility, persons who cannot go to the hospital, or who have some problem with transportation, or who has problem with mobility, or people who are having restrictions in their mobility, where they are confined to the home. For those patients, this home based model can be applicable, and this is known as a home based model. And the key elements of home based model, as I said earlier, where a group of trained people goes to the home and they deliver care at the home level. And the elements can be intersectoral and interprofessional coordination, where it is not only given by one nurse or one doctor. It is a what to say, it is a intersectoral as well as a interprofessional coordination that need to occur. And the next component can be trust and safety in the home based care. Trust is very essential, where the person or the patient who is ill should believe or should trust the healthcare worker or the person who is going to deliver the care. And also, whoever in the healthcare professional point of view, whoever goes to the home and delivers a home based model, their safety is also very important, where the family members who are staying with the patient, are they safe? Whether the safety of the healthcare professional is also a tasks that need to be there. All these comes under the components of home-based care. And holistic management, where the person is take care. Holistic means it is not, as I said earlier, it is not only physical. In all the aspects of care is being delivered to the patient. A holistic management is given to the patient. And non-academic palliative care. And nowadays, if you see repeatedly, we are talking about all these things where palliative care only theoretically the concepts are being instilled onto the students who are pursuing nursing or medicine or whatever it is. So the we have to address this, and the curriculum also need to be implemented so that the persons who are studying medicine or nursing will be able to provide care at the home based setup where the palliative care can be implemented. And spiritual care is another component under home based care, and support to the caregivers. So it is not only the care that we offer to the patient themselves, but also the caregivers, because the caregivers are the persons who are going to stay with the patient for a prolonged period of time, and the support to the caregiver is also a key component. And funding as well as financial support, so all these are the various components that comes under the home based care, where in the home based model a trained group of people goes to the home setup and give care to the patient, and that is known as home based model. Hope all of you are along with me. And the next model of care is the in the palliative care is the hospital based model. So again, from the term itself we can identify hospital based. That means the care services or the delivery of the services are provided in the hospital. Specialist palliative care integrated within the hospital, access to a multidisciplinary team where so there are specialists available in the hospital based setup. So more focus are given on to the curative as well as on the supportive services are also given. And in the hospital based model, the main aim or the goal is to improve the quality of life, to reduce the symptom of the patient, to promote comfort, as well as multidisciplinary team is being involved, and an extra layer of support is given to the patient along with the curative treatment. And again, here in the hospital based model, the key components would be comprehensive care. Comprehensive care means pain is taken care of, again, the symptom control is there, a multidisciplinary team is working on to the patient, emotional support is given, spiritual support is given. So, collaboratively, so comprehensive care is being delivered to the patient. So, that is what comes. And here again, the benefits can be decreasing painful futile interventions as well as increase in patient satisfaction. So this can be the benefits in the hospital based model, where specialists are available in the hospital. So the person who are admitted in the hospital will be receiving a hospital based model, and there are various advantages, especially to improve the quality of life and the symptom relief, and a multidisciplinary team is involved in providing the care. So that is coming under hospital based model. And the next model is the hospice model. So hospice model, it is dedicated end of life. Hospice, when we hear the term hospice, we recognize or we remember it is something that is relevant to the end of life, or people who are diagnosed with a terminal illness who are going to die within 6 months of time, within 4 months of time. Those people are put under hospice model. Okay, dedicated end of life facility, holistic comfort, focused care for the terminal patients. So here, what is the difference or in the timing? Usually we say palliative care is being given from the time of the diagnosis of the cancer, but this hospice care is given when there is a terminal prognosis. Okay, so that is the difference. And the treatment is focused on stopping of the curative treatment. So the predominantly or the focus is towards solely on the comfort. So only for promotion of comfort, this hospice based model is there. And the location, patient can receive this hospice based care in various locations like in the home, in the nursing facility, as well as in the hospice center. Okay, so that is about the hospice model. So hospice means it is towards the end of life, or when the person is having a terminal prognosis, where not only the curative treatment is stopped, and only the treatment or the care is focused on towards the comfort, solely on the comfort of the patient, and that is known as hospice model. And moving on to the next model is the um, community based model. In the community-based model, primary care is given importance, integrated with primary health care, community health workers, NGOs, non-governmental organizations, and local networks. So, in a community-based model, it is integrated with the primary health care, community health workers, non-governmental organizations, and the core components would be home-based care and volunteer engagement. So it is not possible where every time a healthcare professional will be going on to the home and will be giving care. So the concept of volunteer engagement, where people are selected from the community and they are given some training and they will be able to go and render care at the home setup, and integration with the local systems and support for the families. So all these are rendered in the community based model, and there are certain examples that I can quote for the community model, where Kerala model and also a nurse initiated or nurse led management Uganda, which has been existing in Uganda, and another model that is in Tata Memorial Hospital hub and spike model, where the hospital serves as a hub and the community center serves as a spike, and that is known as hub spike model, where there is an integrated coordination of care from the hospital into the regional centers. So these are all certain examples of a community based model. And again, the advantage of community based model is we can encourage home deaths. Okay, home deaths can be increased, where till the end of life, like where we see patients who are admitted in the hospital with terminal illness, intubation is being done for the patient. So many injuries are there for the person who are going to die. Okay, so we can promote home death, and also it is cost effective, quality of life can be improved, and also there is decrease in hospitalization. But again, the challenges are also there, because we need to integrate a lot of resources are needed in order to implement this community based model. Okay, so these are certain inputs on community based model. And the next model is integrated hybrid model. Okay, in integrated hybrid model, it is a combination of hospital, home, and community, continuity of care across settings. So here we have discussed separately about hospital based model, home based model, as well as community. So in integrated hybrid model is a combination of all these things, like hospital, home, as well as community. So this again can be given in the blended care settings. A multidisciplinary team is also needed, and also even it can be connected with the virtual mode also, and integration is also very needed. And here what they say again, here increased patient experiences are there. These are all the advantages, and also quality of life is improved. And again, uh, there are certain examples quoted for integrated hybrid model: in hospital home based linkage, and hospice at home, and also telehealth integration. These are certain examples that is being quoted for integrated hybrid model. And again, if you look into the challenges, there can be logistical challenges where technology is needed, and also cultural sensitivity, because people can be at home, people can be at hospital, community. So again, cultural sensitivity is again a challenge for the person, and logistic barriers and technological barriers can be there for integrated hybrid model. And the last model is the telemedicine model, where remote consultations for follow-up in rural or inaccessible areas are done. And here again, the person will be we need to have telephones, we need to have connections, like where networks are also needed, where in-person care apart from that, is the person comes to a remote area where telemedicine facilities are available, and the remote patient monitoring is done, and the x-rays or the investigations of the patient is being telecasted to the healthcare practitioner who is available on another area, and consultations are also given, and that is known as telemedicine model. So these are all the various models of palliative care. I hope you all have got some idea about all these models of care: home based model, hospital based model, hospice model, community based model, integrated hybrid model, and telemedicine model. And here are certain highlights about the like why, what kind of model is there for this particular scenario. So the recommended model from our group is community based home care model for our patient Mrs. AJ. So community based plus home based integrative palliative model, palliative care model, that is why, that is what we have suggested. And why we have suggested this model, the justification comes here. Rural location where our first patient is living in a remote village where hospital based care alone is inaccessible and unaffordable for her regular visits. And we know about the financial status of the patient also. So, that is the first criteria. Financial constraints, home care eliminates transport costs, leverages community health workers and available resources. If the patient is being attended at the home setup where the community based model is encouraged for this patient, so the transportation can be avoided, all the cost containment can be done, and cost effectively we can manage the patient. Family and social unit, family and neighbors are central to her suffering. Community model addresses this context directly, where not only the patient is taken care of but also the family as a whole and the society as a whole. And that is what we have recommended, this community based and home based integrated palliative care model. Holistic needs, so the community workers can coordinate physical, emotional, and the spiritual care within her own cultural environment. So, in the dimensions of care, we quoted there are various dimensions or the problems existing with the patient. So, we wanted to provide a holistic approach to the patient where the community workers will be able to take care of the patient physically, emotionally, psychologically, spiritually. All these aspects can be taken care in her own environment or in her own cultural environment. So again, identified by the hospital team. So since in the scenario itself it has been given, the hospital team had identified hospital based palliative team initiates care, then transitions to community follow up and true integration. So that is why we strongly recommend this model, that is community based home care model. And here there are a role of nurses across different settings. Initially we have discussed about various models of palliative care. So as a nurse, what specific roles we will be playing in each kind of model, where in the hospital or the inpatient settings, thorough palliative care assessment is being done by the nurses using validated tools. Manage wound and fistula care, so depending upon the wound that the patient is having, odor control using metronidazole dressings, charcoal dressings, and proper barium creams for ulcers. All these classes we had already gone through in the previous sessions. So what type of care we are supposed to give? Administer prescribed analgesics and antiemetics, titrating for her comfort. So comfort is the predominant goal, where we are managing her pain with analgesics and antiemetics. Provide nutritional support and counsel on high calorie, easy to eat foods. The nutrition is also need to be taken care. Offer psychological first aid and therapeutic communication. Coordinate with the palliative care team like physicians, social workers. Initiate social work referrals for financial aid and government welfare schemes. And even they say palliative care also comes under the Medicare or the insurance schemes and are also available, and the government health welfare schemes. So orientation regarding that also can be given. And the next heading is community or home based setting. So here, as a nurse, regular home visits are done in order to assess the symptom burden as well as the wound status. And we also have to train the family caregivers on the basic wound care, hygiene, odor management, and using locally available materials, because they are the one who are going to be with the patient providing care. Counsel the family and the neighbors about the non-contagious nature of the cancer to reduce stigma and isolation. In the history or in the scenario, we said like it is there is a perception about it is contagious. So we need to be clear with the patient as well as the family and the neighbors that it is non-contagious, and in order to reduce the stigma. And connect Mrs. AJ to community health workers or ASHA or ANM for continued support. Assess for depression and suicidal ideation using simple screening tools, because she was very much depressed and there is a chance for her to go for a suicidal ideation. So we need to screen it properly. Help access free government medications, opioids under NPPC and wound supplies, facilitate peer support groups, or connect with cancer survivor networks. So these are all the various roles that we can play as nurses in the community based setting. Palliative care unit, that is in the hospice setting, the focus, as I already told, it is towards the comfort only care and the symptom burden reduction. Nurses provide continuous presence, which itself is therapeutic. Advanced care planning facilitates discussion about her wishes, fears and goals. Bereavement support preparation for the family, ensure a dignified pain free death in alignment with her values. So that is what is the concept. So rather than going into the like all kind of invasive treatments to the patient, a dignified pain-free death can be given to the patient, and that is what comes under hospice setting. As nurse, we can promote teleconsultation or remote setting. In resource limited rural areas, nurses can use mobile health platforms in order to triage symptoms and escalate, provide telephonic counseling to Mrs. AJ and her husband, coordinate medicine delivery through local pharmacies or ASHA. So these are certain kind of roles that the nurses can play in each type of palliative care model. So with this, I shall stop, and I will hand over to Ms. Anandi for continuing the role of nurse. Thank you.
Happy afternoon all. Until now we have seen what are the roles of nurses. Now we are going to concentrate on role of nurses in best supportive care. Commonly we have nurses have different kinds of roles. In palliative care, nurses are the centers of patient care. They functions in multiple roles, that is that given as a clinician, educator, counselor, coordinator, advocate and researcher. As a clinician, they assess the managed symptoms like pain and wound. As an educator, they guide patients and families about the disease and care process. As a counselor, they provide emotional support and listen actively. Nurses also act as a coordinator, connecting different healthcare teams, team members, and services. As advocate, they ensure the patient's right wishes are respected. Finally, as a researcher, they follow evidence-based practices and participate in audits to improve the care and quality. Next, according to Mrs. AJ, we have seen her conditions, and we are going to firstly we are going to do an assessment. We have many assessment. In that, first is pain assessment, next nutritional status, functional status, wound and symptoms, and psychological and social and spiritual. These are the assessment we need to do in palliative care at first. In pain assessment, we are going to identify what kind of pain she is having. We can use numerical rating scale. In nutritional assessment, we need to identify the BMI and oral intake and PGSGA, SGA, that is scored patient generated subjective goal assessment. It is done. In functional status, we need to we need to identify the palliative performance scale. It helps in identifying what kind of functions she is doing and what is deteriorated after she's affected by this disease. Next, wound and symptoms. In wound grading, we need to have the grading of the wound according to the order scale and discharge quantity and quality and ulcer staging. In psychologically, we have two scales, PHQ-9 for depression and for anxiety, GAD-7 we are using, and open-ended spike protocol we have been using. We'll see about the spikes in upcoming slides. Next, in social and spiritual, we have FICA spiritual history tool, the genogram for family structures, and social supportive inventory. Next, first we have seen the pain assessment. In pain assessment, using the numerical rating scale, we have categorized into three according to the scoring. That is, in step one, when it is mild, we can prescribe them paracetamol or NSAIDs. In step two, that is in moderate pain, scoring between 4 to 6, we can give weak opioids, tramadol plus or minus non-opioids. And step 3, that is severe pain. When they are having pain between 7 to 10, we are prescribing them strong opioids like morphine. Next, wound care and hygiene management in Mrs. AJ. Our priority is to manage the malodorous discharge, prevent skin breakage, and restore dignity. Firstly, we are going to concentrate on the vaginal discharge management. In this, we can use charcoal dressing to observe odor. It helps in reducing the bad odor from the wound. And metronidazole gel for anaerobic bacteria, and absorbent pads can be used because this patient is using newspaper rags. For that, we can use a replacement as absorbent pads, and a regular perineal wash and warm water and mild soap can be used to preventing from further infections, and teach proper disposal and soiled material can be teach to the patient. And next, we are seeing regarding the skin and wound care. Assess ulcer using Braden and pressure ulcer staging. We need to assess what kind of food and what staging it comes. And moisture barrier cream, that is zinc, can be used. And repushing for every 2 hours to relieve from pressure. It helps in preventing from pressure ulcers, and dressing, that non-adherent moisture retention can be given, because we are having wound due to increased moisture only. Systemic antibiotic, if infection is present, we can provide them systemic antibiotics. Next, in palliative care, we mainly concentrate on the dignity and comfort of a patient. And in this, provide clean and adequate hygiene supplies and ensure private space for personal care. Involve patients in decision-making care, and deodorant spray and room fresheners. It can be uh, helps in making them feel good about themselves, because uh, when there is no bad orders, the relatives will come and talk to them, like that they can have. Educate family, order is disease related, not dirtiness. We need to educate them, and educate them regarding the disease and the bad order from the patient. Communication intervention, in this we have going to learn about the spike, that is SPIKES. In S, it is setting up. It is private comfortable environment and invite family. In P, it stands for perception, that is ask patients what she knows about her illness. In invitation, seek permission before sharing bad news. If they are having any bad news, I'm going to tell regarding this, we need to ask permission from the patient. And knowledge, give information in simple clear language. We need to talk to them in the language which they are easily in understanding. In emotions, acknowledge, validate, respond with empathy. First we need to listen what they are saying, after that we need to respond to their questions. In strategy, discuss next step, palliative care plan. We have to inform them all the plan, what we are going and what we are planning to them. Next, psychological nursing interventions. In psychological nursing intervention, we have active listening, non-judgmental presence must be present, and validating feelings. We need to validate their grief, shame, isolation. We need to validate them. Next, facilitate family meetings, restore relationship. Community education. It helps in cervical cancer not contagious. We need to educate them regarding the cervical cancer is not contagious, and they can be treated by providing palliative care. And identify meaningful activities within the limitations. Support patients remaining role as mother and wife. We can tell them that you can remain and do care for the children, you can take care of the family also. Then facilitate access to social welfare and financial aids. We can teach them. Then family supports and caregivers educations. In this we have categories of disease education, emotional support, caregiver self-care, hygiene and basic care, medications management, end of life preparation. Family members and neighbors must be included in this. It helps in proper development. In disease education, cervical cancer is not contagious. Educate family and neighbors, reduce fear-based isolation. It will help in communicating with the family and improve the communication between the family and the patient. Emotional support, encourage family presence, validate caregivers' burden, teach active listening skills can be taught. In caregiver self-care, a career burnout recognition, respite break, community support, and a group of caregivers can be given. Hygiene and basic care, teach catheter care, wound dressing, basic positionings, and nutrition support at homes. It helps in continuing the care to the patients at the home setup also. In medication management, safe storage, administration of oral morphine, recognize overdose signs, pain dairy. We need to teach everything about the medication, the side effects, and everything to the caregivers. It helps in providing good care to the patient. End of life preparation, advanced care planning discussion, cultural and religious preferences, legal wishes. We need to ask them regarding the cultural and religious preferences from the family side, so that it can be helpful in providing good care to the patients. Hope you all understand all the slides which I have explained. Now we are going to have an S or no session on the role of nurses in best supportive care. I will ask questions to you. You can respond in message, or by unmuting you can respond. The first question: do nurses act as educator for patients and families in palliative care? Yes.
Yes.
Yes, it's a correct. Nurses act as an educator during a palliative care. Next question: is palliative care assessment focused only on physical symptoms?
No.
No, it is not fully concentrated on the physical symptoms. All the psychological and social, spiritual, everything has been concentrated in this. Next, does pain management follows a stepwise approach according to the World Health Organization ladder?
Yes.
Yes, it is correct. Next question: are strong opioids used for mild pain?
No.
No. According to the pain, mild, moderate, or severe, it is changed. It is mild. For mild, we are not using strong opioids. Next question: is maintaining patient's dignity an important part of wound care?
Yes.
Yes. In palliative care, first we are maintaining the dignity. It is the first main we are using in palliative care. Next question: does vaginal discharge management include infection prevention?
Yes.
Yes. Next question: are pressure ulcer prevented by regular repositioning of the patient?
Yes.
Yes. Next question: is the spike protocol used for delivering bad news?
Yes.
A spike protocol is used to deliver bad news. Next question: do psychosocial interventions include emotional support and active listening?
Yes.
Yes. Next question: are caregivers educated about both patient care and self care?
Yes.
Yes. I hope you all understand about the previous questions by revising by yes or no question. Now, thank you for listening. Now, I will give over to Ketna ma'am for continuing this.
Okay, good afternoon, all dear participants. So today, with the case scenario, we have learned a lot about the dimensions of palliative care, models of palliative care, and role of nurse. All three aspects were covered. So as dimension, it is physical, psychological, social, and spiritual. And as models, we have like hospital based, community based, hospice based, telemedicine based, home based, and integrated model. And finally, role of nurse for each symptoms as well as communication and psychological. Totally we have covered according to the case scenario, how AJ has suffered and how we have to take care of AJ, the case scenario AJ. So this is why we want to talk about all these things, why palliative is important. We have learned that so many times. Now, with the evidence by the Lancet 2025 Global Palliative Care, they told nearly 73.5 million people globally suffer with seriously health related suffering. Among that, 80 percentage live in low and middle income countries, and 74 percentage of increase in palliative care burden from 1990 to 21. Nearly 74 percentage is increased because of increasing elderly population as well as increasing disease burden, and 63 percentage are non-dozens living with illness and dying. Okay, so cancer is a leading cause of suffering. 23 percentage of cancer patients live with serious health related suffering. This serious health related suffering is not as you think like seizure or some emergency. Not only that, a health related suffering which starts from pain till the patient has all the psychological symptoms. So the health suffering is not only about physical. The journal also says low middle income countries bear 80 percentage of the burden yet have minimal access to palliative care resources. They don't have adequate resources for palliative care. In our scenario, like AJ also, she came only at the advanced stage to palliative care. She known where the palliative care is present or accessible to her. So coming to ethical issues, we also thought to discuss on ethical issues and the barriers and challenges what the world faces related to palliative care according to this scenario. If you see, first is autonomy and refusal. Mrs. AJ, she refused the treatment. So, whenever a patient refuses treatment, we will say that this is good, the treatment is good and it will help you to improve. But here, the nurse must respect the informed refusal while she is ensuring she understands her options. She is in advanced cervical cancer, so you have to understand her. And beneficiaries versus non-malfeasance. Here, the balance benefit of interventions with harm of forcing unwanted treatment should be there. For example, Vaginal discharge is her major problem, where it is for her beneficence. You have to treat her, and you are not giving an unwanted treatment like a major surgery. You are not asking them to admit for long time so that she could not be with her children. So this is how you have to segregate the intervention which is benefit to the patient and which is an unwanted treatment. Coming to justice or equity, yes, poverty should never determine access to palliative care. This is very, very, very important aspect where we have to take to the next level. We have to advocate for free and subsidized supplies and home visit. This is very good in Kerala model, where it has been done in a wide range. In other states, almost they never, some of them would heard the name of palliation. So this should not determine their access. Palliative care should be access for everybody. And coming to cultural sensitivity, rural belief, stigma around cancer and gender role should be influence. It should not influence the care. So these are the ethical issues what Mrs. AJ is facing. Coming to barriers and challenges what we face in the scenario as well as in the palliative care. First is system level barriers. There is shortage of palliative care nurses who have trained palliation. That is why a module has been inculcated in the students curriculum, and we are given training to teach to the patients for the module also. But this is not enough. This is the initial initiative what has been taken. And opioid availability and accessibility to everybody both in rural and urban areas, it should be improved. Lack of home care infrastructure in states is going home by home for care for the palliative patient is less compared to the other national policies or programs. When a national program for tuberculosis came, it was like a range, like a wave. It went to all the homes. Most of them got benefited, and we were able to achieve our limits. Palliative is not started as a wave. It is emerging very slowly, and this should also come to home in the infrastructure also. Fragmented care. Fragmented care, this word says clearly that, as Sophia ma'am told, the care will be in the hospital for the patient. The communication and the education given at the hospital is separate. When the patient comes to community, there will be lack of care. Sometimes if they provide care also, they don't know what has happened in the hospital. So this fragmented care should be like a chain of survival in palliative, where the care should be started in hospital. It should be connected to the community, to the home. So this fragmentation should be connected with the chain. These are all the system level barriers we are facing in palliation. Coming to provider level barriers, as we limited palliative care education in the undergraduate nursing curriculum. Yesterday we spoke 1.5 hours on this, how to integrate palliative care education in the nursing curriculum. Already palliation is there and nursing curriculum is there. How to integrate in the nursing curriculum we have discussed yesterday. So the next is moral distress among the provider level nurses. Okay, the nursing people who is taking care of the patient should also be trained psychologically strong. They also should be physically strong. So that should be given more training to the nurses. Communication skill gaps, as I told, the teaching to the patient, or it may be to the caregivers, or it may be to the ASHA, that skill gap should not be there. That is one level of the barrier. Coming to burnout and compassion fatigue in palliative care nurses. When I see a patient, when they get better and they go with a great smile, I will be very happy if I take care of a patient. I see the same way I'm taking care of another patient. I know the patient is at the end of the life, and I see whom I have taken care with the compassion is no more today, and everyone around the patient is crying. It is not only the emotional burden of the caregiver, it is also the compassion fatigue or burnout to the palliative care nurses also. So, though the nurses take care of the patient for a long time or a short time, you see they'll create a communication bond, or they will think each thing. Today the patient pain has been improved, I can take care like this. Today the patient needs some psychological time or communication time to the patient. I each step I have gone with the patient, and finally I'm losing the patient every day. So how will be the nurse's mindset? So this burnout should be taken. Either we have to educate and give counseling to the palliative care nurses also, and patient and family level barriers. This could be addressed with the scenario itself, stigma and shame. So Mrs. AJ delight to go to hospital because they would give a big diagnosis, or they fear of judgment that she has done something wrong. She has not taken care of her properly. Health literacy, lack of awareness about palliative care is most important barrier, where we as a nursing faculty or nurses, those who have to take to the population or the community that palliative care is necessary. It is an available option in the hospitals as well as in the home. Financial barriers, refusal of treatment is one of the barrier, and inability to afford supplies, and cultural beliefs like fatalism or reliance on faith healers. uh, Sometimes if I get a disease which is not curable, I may lose all the belief of spirituality and the faith. That is one of the barrier. Why I have past 1 year I'm working in oncology, where I see the patient, they lose the hope because there is no treatment for me, there is no cure for me. Then why my family has to spend on me? Why my the which amount they are spending on me will be useful more for my children or for my grandchildren? So that is one of the reason why they refuse the treatment. If you explain what is palliative and how it benefits to them, definitely they will accept for the palliative care. Coming to gender dynamics, women like AJ may lack decision making power. So she is not an breadwinner of the farm. She is earning, but not that much. So she could not take a decision for herself. Most of the women in our community could not take a decision for them whether they need this treatment or that. Even elderly could not take a decision for them. Most of us in the hospital explain their disease progress to the caregivers. Ask your son to come, ask your daughter to come, or ask your son-in-law to come. So you explain to them because they better understand, because they are educated. If the patient could not understand fully what you are telling, so you will tell caregivers could understand better. But who will be the decision maker? Who has the right to take a decision for their own treatment should be the patient. Most of the geriatric people, when they know about the advantages of each care, definitely they would go for palliative. So that option is not given, that awareness is not given, not it is going at least to the caregivers, not to the patient. Coming to societal barriers, rural and urban division, this is a major problem, where in urban area we have many hospice care or palliative care centers, but not in rural areas. So that is a big gap. And social stigma around cancer, that community isolation is a biggest barrier. Still they have the social stigma of cancer. Two things: You did something, so you got cancer, or you got cancer, I may get the cancer. So this stigma, so that is biggest barrier in society. So that most of them in rural area, they will not disclose that they are identified with some illness. Okay, and caste and gender inequalities also affect as a barrier for the patients. So what are the barriers for the palliative care? Is system level barriers, provider level barriers, patient and family level barriers, and societal barriers. So now what we could do to come across these barriers, how we are going to throw out all the barriers, is by some of the recommendations which our team has delivered us. First, clinical practice. Integrate the palliative care at earlier. When you diagnose, don't wait until you get to end of life care. So this you have to integrate in the palliative care earlier. Who could integrate this in clinical practice? When a patient comes to the physician, when a patient comes to your surgeon, he should know that this patient should be shifted to palliative care. There is an option of palliative care for this patient. This integration should be done at earlier so that patient would be benefited. Nurse-led symptom management protocols should be available in the community area where they could handle the wound or fistula or pain, counseling for the depression, all that could be done. And coming, the next recommendation is task shifting. This is what I told when communication barrier is there. Train ASHA and community volunteers under nursing supervision for basic palliative tasks. So one area is allotted for one person or one ASHA training. How many houses they visited? In that, how many of them is in need of palliative care? Per week, how many visits they could go to their home and see what is the serious health hazard or suffering the patient is undergoing. Coming to order and wound care kits should be available at the community level, at the home base level. Psychosocial screening at every home visit using some simple tools can be done. Even just sitting and communicating with them what you're thinking about, what your face expression would tell us. So give some questions to them so that they will ventilate the full agony of them, full they are thinking what they are thinking about. This is the recommendation which we could do in a clinical practice. What the healthcare system should do, they have to expand the opioid availability to all the primary healthcare centers under the nurse prescribing authority as in the Kerala model. They can establish a nurse-led palliative care clinics at community health centers. Financial protection schemes like Ayushman Bharat or state welfare programs. Still, many insurance companies should give access to the palliative care. This should be spoken out a little higher way, that in the insurance schemes, palliative care is added. Definitely, most of them would be benefited. 24/7 palliative care helpline staff should be there, and they should be a trained palliative care nurse. Coming to policy, we should mandate palliative care training for all community health nurses and recognize palliative care nursing as a specialty with structured career pathways, like we have critical care nursing or oncology nursing. Decentralize morphine distribution to the district level stores. This will little bit benefit the palliative care patients. So till now we have seen what all the challenges and recommendations for palliative care patients as well as serious health suffering patient. So finally we are with nursing care plan as a summary for Mrs. AJ, and what all the problems she had and the diagnosis according to that. Chronic pain related to tumor invasion, our goal is to reduce the pain less than 3 by administering WHO later analgesic. And impaired skin integrity related to incontinence, our goal is to heal the ulcer by wound dressing, mainly charcoal dressing and moisture barrier, and 2 hourly you have to reposition the patient. Ineffective coping related to depression and isolation, our goal is to improve coping by a therapeutic communication and counseling. Mainly we have to educate to the family and the neighbors. Self-care deficit related to weakness and pain, our goal is to give the assisted activity of daily livings by supervising the hygiene, assistive devices and family teaching. Social isolation related to stigma and order, our goal is to reintegrate community education, order management and support groups. Spiritual distress related to loss of the purpose, our goal is to restore the meaning and facilitate the religious observance, life review, and a chaplain referral. All this could be done as a nursing care plan. This is the final thing, how we are going to prepare our future nurses to take care of the patient with suffering, serious health suffering. First, curriculum should be reformed with case-based and clinical learning. Today, with the case of AJ, we have learned how it should be physically addressed, how it should be psychologically addressed, and how spiritually it should be addressed. So this case-based and clinical learning should be reformed in the curriculum. Yesterday, we spoke about that too. And simulation and skill labs. Simulation and skill labs mainly on the patient standardized patient simulator, like task training. Which are the tasks needed for the palliative patients? Injective feeding, home catheter care, prevention of bed sore, prevention of infection, immune boosting diet. So these are all the things which we need to teach them in the simulation as well as in the skill lab. Even communication skill training, both verbal and non-verbal, could be given in the simulation part, like a role play. One should be as a patient and one could be a nurse. The students could have a communication skill training, how they speak to the patient. Most of our students go to the patient and directly they'll start with the history collection. Even if they first years go, they'll have the history collection paired with them and they'll start to do the communication. But it is not like that. You have to see their non-verbal cues, whether they are ready to speak, and then we will be making them comfortable to speak, and then they could speak. Sometimes our students will say, "Ma'am, no, they are speaking only to you, they are communicating to you but not to us," because we have to observe their non-verbal cues so that they are ready to speak, or you make them comfort to speak. The next is reflective practice and values clarification. Just leave a student inside a patient with palliation, go get after coming back, you ask what all the things you learned from the patient, what are the values you learned, or what all the ethics you learned from this patient. That will give a reflective practice to them. Coming to community immersion, palliative care home visit posting should be immersed to the students. And interprofessional education, like seminar and discussion after the posting, each student will be in each area and they could discuss about the case and come to a conclusion. So that education could be given. Finally, faculty development program, because faculty should be enriched with the palliative education so that students could be also done. So in view of that, we 32 faculties of PSG College of Nursing is enrolled in this faculty development program to learn more on uh, palliative care. So today we have seen palliative care is a multidimensional, community-based integrated model is used for the patients, and the evidence clearly show that we are increasing with the palliative care patients, and how to manage symptom, wound care, family education, dignity, and restoration are nursing priorities in the case. So, with this, palliative care is not about dying, it is about living with dignity until the end. Do you have any doubts or clarifications?
Shall we have a discussion on this? I'm not sure like how many of you are there.
Yes, ma'am.
Thank you, PSG College of Nursing and the entire team for taking AJ's case and presenting it so well with the video and with the background materials. This topic has a lot to do with nurses, and that's one reason I jumped in when Shiba Chechiko asked me. So, shall we have a 5 or 6 minutes discussion on this? I'm not sure, like, if the time is okay for you.
We can discuss now.
So we learned about serious health related suffering, and why in spite of these many lakhs of people in India are living in serious health related suffering, as nurses we are unable to address any of these issues. Not an essay type, but this is something that there is a major gap, because
System failure.
though we are taught to take care of the holistic, person centered, comprehensive care. That's what as nurses we do. And serious health related suffering is something very comprehensive, very holistic. It's not disease directed, it is not pathology oriented, it is nothing to do, it is very much person centered. But what is that barrier between nursing? I'm talking about faculty, staff nurses, working in the primary health care centers, who are maybe in some other areas. There is a big divide between nurses and these patients, in spite of billions are in need, suffering with SHR. And that's something that um, very distressing in palliative care, because as one nurse in maybe in the Union Territory of Pondicherry, we do have maybe like maximum 5 or 6 nurses to cater a territory. So there is something, a big divide and big gap in this field, and we have to focus on training for sure. But then again, as Madam said, why TB had a rampant, like uh, a fire kind of thing, but palliative care is not picking up. So answers to these questions are very important to integrate palliative care in the health system, into the curriculum, into the clinical service, because there is resistance. There is system level resistance. There is patient level resistance. That is family level resistance, because we really don't know what exactly is palliative care. And to have a few corrections in the thing, from Dame Cicely Saunders is a nurse. She later turned to doctor, upgraded herself into a doctor. So it's Dame Cicely. Cicely is a female, and then she's the founder of modern palliative care. So she as a nurse, she understood that there is lot much to do for dying people, and she understood that as a nurse, that prescribing power was not given to her. So she upskilled herself. And the other thing was, nurse prescribing authority is not there in Kerala also. So we in Kerala, like we are trained in Kerala, but we don't have nurse prescribing. But we are trained to understand and to support our team. We can tell that, okay, doctor, this is what is required. In my hospital, I'm the consultant. So I have to say, doctor, this is what we require. And can we give a prescription? And maybe a cardiologist will look into that when a nurse tells that, and that's fine. And the tools part you discussed. So imagine if you have all tools for all the symptoms, how already the patient is very deteriorated. And we have a tool for depression, we have a tool for fatigue, we have a tool for constipation, we have a tool for pain, we have a tool for everything. And that's why we have one tool for serious health related screening now. And that's the main point. And that one particular thing, if you ask me who should master, I'll say nurses should master, because that particular screening is completely in our hand. And I really don't want to give it to other professionals too, because that's where, okay, see, this patient requires palliative care, then this is the proof of it. Another point I discussed was early integration. Early integration, when a patient is diagnosed with cancer or something else, when we say the patient has to be in palliative care, it is not like patient has to come to palliative care. That time, what we call it as, like in palliative care, there are different aspects, the multiple specialty. So one aspect is supportive care and palliative care. So along with chemotherapy, along with any disease modifying treatment, like if it is cancer, chemotherapy, if it is kidney failure, dialysis, palliative care will be an additional layer for the patient. And gradually, if patient has regressed or the disease is not responding to the conventional therapy, patient will be gradually coming to palliative care. So supportive care. So that's how we see patient. We will be seeing, we will not even tell our patient, I am coming from palliative care. Because why, who referred? Why are you coming and saying me? I didn't ask for a palliative care referral. I have heard it many times. Maybe I go for psychological support. Maybe even my tag later changed to supportive care. Because the moment when you see me as a palliative care nurse specialist or nurse by profession, why are you coming to see me? Is there anything that I don't know about myself? I, so there is a stigma associated with palliative care too. Why? Because still palliative care is associated with death and dying. And that's where supportive care, that part, and then the regular palliative care. And when it comes to end of life care, it's end of life care or hospice care. Hospice care can be given to 6 months or 1 year. And hospice care is a philosophy rather than a setting. Like we provide hospice care in a palliative hospice. Hospice is a setting as well as a philosophy of care, wherein very focused end of life care is provided, wherein nurses are trained how to manage all the distressing symptom, how to manage last hours of death, how to manage if there is an intractable symptom arise, how to give sedation if there is required, how to get the consent for a terminal sedation, and how to monitor a patient if there is something like that, and how to support the patient's family on grief and bereavement, how to follow up with them, and those things, how to put them DNA CPCR activation and all those things. So this is a very wide topic, and still there is resistance because nurses are others are still thinking that we are only with death and dying doing 7 or 8 death care and things like that. And the other part is for AJ, you mentioned that community-based palliative care. When coming into detail of it, let me ask you in this way: which would be best, having a home care model or a community-based model?
Integrated.
Wherein a nurse, doctor, and a psychologist or social worker going to visit AJ at home, or a community-based model?
Integrated with community and home care management.
Okay, so that is exactly community. But the problem here is to have it in place, the community should be sensitized to palliative care. In community based, the screening, the need assessment, the community is protecting it, the patient. the patient is covered with the community network of people as in Kerala. There are many compassionate communities across globe. If you type compassionate community, you will get into it. And one of the famous model is Kerala model. So now what is happening is for Tamil Nadu, home care, nurse-led home care will be a very good model because this nurse, this is how Kerala model has started. She is well positioned to integrate or to sensitize the community and to slowly integrate into the primary healthcare systems or the grassroots level health system. So the main problem now, right now in front of us is currently in this moment, in this second, there are lakhs, thousands of AJ in your locality who does not have access, who cannot afford, who is self isolated because of the stigma, who does not know where to call for help, in screaming. The pain cannot be tolerated. No woman, no man can tolerate that kind of severe bone, crushing bone type of pain. And still, there is a wide, and the gap is widening. How much ever initiative integrating palliative care into health system, national policy of palliative care came, integrating palliative care to medical, nursing, dental curriculums, the the gap is just widening. And that's one area where maybe in the next phase, and now nursing colleges are actually setting up different projects in palliative care, wherein nursing students are taking multiple small projects to do need assessment, a baseline screening of how many patients, how many people require palliative care in the community, in the hospital, and what are the layers of serious health related suffering happening. How can we address it? And again, I'm like pressing on it. We do have a major role in this, but unfortunately, maybe because it's not so glamorous like CCU or hemodialysis or I don't know the exact reason. But in spite of multiple attempt, we are not getting a lot of patients, a lot of nurses to take a palliative care. I'll just show, like, this is a nurse from Tamil Nadu. His name is Terry. Oh, sorry. So this is Terry's recent study. Supportive and palliative care needs among older adults in India, an estimation using National Representative Survey, and 7 to 10 million Indians need palliative care, but less than 4% have access to it. We do have major roles with this, and this is one of our 2022 paper. I was a corresponding author into it, author of it, and we do have lot of interventions, planned. Nothing is coming into the nothing is coming to the implementation phase. We had barriers with the registers to integrate, to show, can you add palliative care into one of the modules? Never, never, nowhere we were getting support. And I'm very happy that PSG has taken up initiative to take it up, and I wait and eagerly wait for more projects or research uh, which narrows down the gap. There are lot of nursing articles, nurse research papers coming up, which is still widening the gap. Something to narrow down, something to bridge the gap, something to glue it up. Still, the patient is on one island, and we are in the other island. And among the healthcare professionals, it is nurses who can build a bridge, who can cross to the other island. And maybe some initiatives I'm expecting. Any doubts? Because this is such a philosophical area wherein every patient requires individual support. We don't have a tailored thing, and it is all depending upon the training that the nurse receive, the knowledge that she possesses, and the skill that she possesses. Because not any, there will be only one AJ, even though there will be some other person with the name AJ, with the same disease, with the of same age, her needs, problems, um, requirement is all different. And how we plan is again by collecting, as Madam said, like understanding the non-verbal and verbal cues, to know how to do a holistic assessment, to ask the right questions. We will not be. Some people say we are not in position to break bad news, but we are in a much more better position. Somebody is completely broken down, and we are going to bring them back to pieces, supporting them in the most vulnerable time of their life, anybody's life. Caring somebody in ICU. I am a CTVS, when I'm postgraduate nurse in cardiothoracic by training, by initial training. I even with 6 or 8 drains, somebody who is going to die, okay, I need to check monitor, I need to look into all the support system. But here somebody is dying, who is conscious, who is oriented, comfort. You have to keep sure that the patient is comfort. You have to do the show in front of family. And that courage, the training that you need to require, in terms of courage to do everything in front of a family. When it is children, it is even more difficult. When a child is dying, we have to support mother, we have to support father, we have to support sibling, we have to make sure that the child is comfortable. There will be 100,000 questions. Sometimes I myself ask questions, why this is happening, or what is the justice in this. And there again, Madam has touched upon the moral distress. We build up moral distress. We will have all those, piling up feelings, and then we release it, because we are even trained in that also. So we release it and then wait for again to fill it up. So these things, everything, I think when we know all these things, nurses are getting reluctant, but it is not like that. Palliative care is very rewarding, very wonderful branch. I don't know. I still don't know why nurses are not taking it up. It is one branch where nurse can take leadership, nurse can lead clinical roles, nurse can lead clinical teams. I'm so happy to say that I'm leading a clinical team. So their nurses can lead clinical teams. So I hope college will find some great solutions and projects, eagerly waiting to hear more projects from your side. Not everybody are positioned. I can really understand. Not all colleges are positioned to take a projects, but there are good palliative care units near to PST, I believe. You also have a great unit.
At PSG only we have units.
Yeah, you have a great unit. So collaborate with them. Just what are the major problems? What are the issues you commonly found in palliative care? How many of them have oral issues? And what is the severity of their oral issues? Nobody talks about oral issues. Nobody talks about sexual issues. Nobody talks about financial problems and discussions. So, anything. And well done. I'm so happy and well done.
I
Great work,
feel
and
the
appreciate that effort.
emotion when you speak and how much you wanted to do in palliative care.
I mean, it has been 10 plus years, and we thought by 10 years we will reach somewhere.
It's
Horribly, we
really
have
touching.
not reached anywhere. If you have
Yeah,
connect
from
association with
PSG,
Shivchichi, how many
we take it
sessions
as an
daily she is
assurance only.
taking?
Our faculty will definitely do their best. Actually, we are having a plan. We have already initiated some nurse-led clinics in our hospital, and our management is promoting this. We have lots of administrative support too. With the nursing service and college, already we are integratedly working.
So we will definitely do something in palliative care.
Nurse-led clinic is one of the future promise in palliative care. It's well supported across globe.
Yeah.
So now organizations like St. Christopher's are like funding on nurse-led models. So there is no other way to reach out to the people. And if there is any marginalized community like wherein I work, the only access is nurses. I work for 2, 3 marginalized communities, like fisherman community, transgender community. The only access is nurse. So nurse-led model, again, it's like nurse-led model is the future. That's the only way you can ensure coverage for palliative care services. Patient cannot come to hospitals. If they can come to hospitals, not all hospitals have palliative care. So access divide is there. Again, if palliative care is there, not all hospitals have opioid availability. Another divide is there. So when we are terminally ill, somebody should reach where they are. And in this severe shortage level, I don't think any doctors can bridge the gap. So that type of training, and I'm so happy that you have taken up nurse-led models. Nurse-led model is something that there are integrated. There are a lot to think, a lot to work on it. And Tamil Nadu has Makkale Thedi Maruthvam, but it has collapsed. I mean, not working so well. But if they could integrate into it, we have created even greater, brilliant concept plans. But then resistance. When we integrate into primary healthcare, Makkale Thedi Maruthvam is such a brilliant model. That push is not happening. I think they are not trained enough. They are not trained by nurses, I believe. I don't know exact reasons. They're underutilized.
Underutilized. Because
Yeah, we
even
cannot go to
PHOs are
ASHA
BSc
workers again.
graduated nurses. They are very much underutilized.
We cannot go to ASHA workers because they have already have vaccination program, tuberculosis program, maternal health program, other screening, and if on the top any other infectious or communicable disease come, they are overstretched. So that is happening in all other states. But only in Tamil Nadu we have MKM program, MTM program. In Kerala we don't have this. We don't rely on grassroots level workers also. We have community palliative
Tamil
care
Nadu
nurses.
only
We have
started this MTM. West Bengal had adapted this. So they are having this program.
MTM.
Yeah. West Bengal has.
Okay. West Bengal had a similar palliative care model like in Kerala. It is called West Bengal palliative care model, but it collapsed actually.
That is not, but this Makalai Thedi Maruthuvam, a similar concept is there in West Bengal.
Okay, great knowing. I have to learn a lot. But the palliative care model was in 2014, 15, based on the slum areas of West Bengal because one of the project I was working was a sister project of that West Bengal project. But it collapsed because the moment the top people who were advising that changed, the system collapsed. So it was a system collapsed. We only have now literature on it. So that was one project wherein Kerala model was trying to replicate. And we understood that a model cannot be replicated. Model has to be evolved with the state, with the culture, with the cultural background. That West Bengal model was something that trying to translate. We had that similar models in Thailand and all, but West Bengal model couldn't continue. Now we have another nurse-led model in West Bengal by our Ruma Abidona Hospice, RH, wherein a nurse is the CEO of a hospice. Her name is Maheli, and she is doing a lot of outreach programs. And she has a hospice wherein patients are with all the head, they pick them up, they do wound dressing. It's an RH is coming to
TMC
becoming a
may have.
training center in palliative care.
TMC has, I think, Tata Medical Center.
Ruma Abidona, RH Hospice. If there is anything, just I can be of any help, just let me know. I'll post my email ID here. Thank you so much.
Thank you for facilitating our team, ma'am. And from the day
So
one,
thank you,
you
ma'am. Call me Anu, please. I am.
thank you so much for being with us for all those days, and we have disturbed you more. Thank you so much, ma'am.
No. Pleasure is always mine. And
And I
this topic
also
has so much.
thank Pallium India, Shiva ma'am, Neha, and Hannah for giving us this opportunity for our team on this topic. Thank you so much to all of you.
An excellent presentation. Thank you.
Thank you.
Thank you. Thank you
Thank you,
all.
ma'am. So, so any doubts, anything? Okay, participants, kindly ask your doubts, or you can share your feedbacks.
I cannot see anything. I can read only names. If you want a screenshot or pic for recording.
Sorry, ma'am.
No, do you want any picture and a photo screenshot for recording purposes?
No. I'm already recording this. So, just asking
Okay.
the feedback. So they are saying
Okay.
excellent presentation. Good. Thank you all.
Okay. Excellent. It was excellent presentation.
Yeah.
I loved the video. That's the first time I'm seeing a video presentation. We have seen multiple layers of, very attractive slides, but video is superb.
That was made by Dr. Bhaskar and Akila.
Amazing. I mean, thank you so much.
Thank you.
So
I
thank
have
you.
put my mail ID over there. If there is anything I could do, just write to me. Okay. You have already my phone number. I am almost always available.
Thank
Thank
you.
you.
So shall we wind up for today, ma'am? So, Anu ma'am, thank you for facilitating the session. Thank you. One second, I missed the names. So, thank you, Dr. Jaydeepa, Professor Sophia, Miss Kirtana, and Miss Anandi. Thank you for taking the session. It was amazing. So happy to be a part of this, and we can wind up for today. Thank you. And tomorrow we have another session. So, I'll see you tomorrow. Thank you, ma'am.
Thank you.